Because I think they're also the places that are producing a lot of nurses, but they don't have, many of the countries don't have the fiscal capacity to be able to absorb those health workers. So it's not that they're not needed for service delivery by the populations in those countries, it's that they don't have the ability to employ them all or to employ them all in a good amount of time. I was in Malawi last year, and they told of how they'd been having nurses sit for 3 to 5 years after qualifying as a nurse before they could be employed in the public sector. Now imagine that's longer than the length of time you spend in your nursing training. So how much your skills depreciate in that time before you can be employed.
Well, I guess the thing there is that if you look at the kind of law of supply and demand, you've got an issue where one country has an oversupply, can't afford to find positions for its nurses, whereas other more wealthy nations have the oversupply. So, Susan, to come to you, it's the answer seems obvious, doesn't it? You know, we need to kind of create the environment and the opportunity for those in areas of oversupply to come to those in undersupply. Is it that simple?
Not really, yeah.
I had a feeling you might say that.
Yeah, unfortunately. In many countries, it's very complex. As Jerry Lynn said, we work in many countries. ICAP is in over 40 countries. And I had the privilege of running a program to build the capacity of nurses across 10 countries, and we worked with 22 schools of nursing, and our mandate was to increase the quality and the quantity of the nursing workforce. And we, I think, successfully were able to do both, but the challenge, as was said by my colleagues, is absorption. And Lesotho is the best example. We worked with every school of nursing in the country to rapidly increase the number of nurses trained, which the country desperately needs. And I worked with the Minister of Health and spoke with him, you know, I'm getting challenged because the nurses aren't being absorbed. And he said, we would love to absorb the nurses, but we are limited because the number of public servants, because of global agreements and loans, we can only have a set percentage of public workforce. And although the nurses are there, ready, willing, able, and well-trained, they can't be absorbed into the workforce. But also, as Alison said, many nurses want to work and they volunteer. I work in Sierra Leone, and nurses will volunteer for years in the hopes of getting a paid position.
So Robin, to come to you next then, how easy or difficult is it for those qualified nurses to leave these countries in which they've trained and come to places like the US, the Kingdom of Saudi Arabia, the UK, etc., etc.? What are the barriers to them being able to have that level of ability to move between economies?
So interesting, one of the biggest barriers is a disparity in economics. And we don't think about it, but those who are able to leave their home country to go to other countries have some sort of social and financial support for them to leave the country. So that creates this difficulty with the nurses and midwives that remain, and we also have to include midwives, that remain because they are not the ones that are well-resourced, so to speak. So it's a double or a triple bind for those that stay behind, and especially, as Susan has mentioned, who cannot be absorbed into their communities.
So Howard, what's the answer?
I'm going to just push back on challenge this, that we've got some countries which have got an oversupply of nurses. I see shortages right the way around the world. But the countries who are recruiting from countries who have a ratio of, say, 10 or 20 nurses per 100,000 population to their country, where they already have 90 or 100 nurses per head of population. So they're exacerbating that inequality. What those countries can't afford to do is they can't afford to employ those nurses. I was in Ghana and heard the same stories of 2 or 3 years of nurses who, the government say, look, we have the health needs, we have the population needs, but we don't have the money. And this is where I'm keen to push the profession as well, to say we have to start to get involved in some of the macroeconomic debates on this. Because you say to those countries, why aren't you funding more into health in your country? Some of the answers they'll give, our foreign debt, sovereign debt, is more than our health budget. when we bear the costs of educating these nurses, we don't get anywhere near an equivalent amount back when they're recruited. As in the previous session, I raised suggested some numbers about how much offsetting of costs could be involved here as well. So I think that we as nursing have to go into some of these areas of economics as well as health as well. And the one other point that was interesting from what all of my colleagues were saying, the patterns of migration and mobility are becoming more complex. This isn't just about nurses from India or the Philippines. The Philippines now reports having 250,000 shortage of its own coming to Europe. We're seeing nurses, they may go to EMRO and then move on to Europe. A report just recently, nurses going to New Zealand because they can access a trans-Tasman agreement to ultimately move to Australia. And the US is still an ultimate destination because of money. So the migration patterns we're seeing are also more complex. And some nurses are very, very savvy about the stepping stones that they're taking to get to an ultimate destination. And an ultimate destination, sorry to say, bottom line, where they're going to be paid better.
Absolutely. I mean, it's a really interesting point that you raise about the fact that there are still needs and requirements in these countries for nurses. But if the money's not there, the money's not there, right? I mean, any of you on the panel got any solution to that one? I mean, we can't create more funding in sub-Saharan African countries that are laden with debt, can we?
Well, so one of the things that I have a multinational research consortium, and we're looking into how do we examine and understand what promotes economic well-being. This is a relatively new concept that the OECD is also looking at, because honestly, I've never met a nurse who thought they got paid enough. Doesn't matter what country they're in, but it's one of these things where, but your salary should be within that range where you can feel a sense of economic well-being, where you have it both for the short term and the long term. So we're trying to understand, what salary range would be enough to have an economic well-being for your workers and for your nurses, because if they have that, they're much less likely to migrate. Latin America is a very good example of this, because most of the time the nurses' salaries, with a few country exceptions, are falling into that economic well-being range, albeit sort of on the border of there might be a problem. But they don't have a problem with migration that some other parts of the world do.
Susan.
Yeah, I would flip the question and say, can we choose not to pay and absorb these nurses? Because a country is hurting itself when it doesn't hire and pay nurses, because we know a sick population is not a thriving population, and we have to, I think that's one thing we need to make very, very clear. You invest in nurses, nurses drive healthcare globally. Everywhere, even in the United States, where we have many, many doctors and specialists, nurses are the drivers of healthcare. Nurses run hospitals 24/7. And so investing in nurses is wealth. And I think that has to be known by ministers, not only ministers of health, they know that, but ministers of public works, ministers of defense, and ultimately the presidents and finance people who are making decisions. It is the best value for money to invest in nurses if you want a healthy, thriving, economically robust population.
And the link between health and wealth is obviously very, very clear. I guess, I mean, and Howard, I'll come back to you on this one, because I think you had some interesting things to say here. Is there anything that can be done by wealthier nations? Again, I'll use the examples of the Kingdom and the USA. Is there anything that can be done by those countries that are clearly reliant on the global workforce marketplace for their health professionals in general and nurses in particular, to help to improve the situation of those economies that do need the nurses but are still ultimately the suppliers? What's the responsibility of those countries?
I think let's push them on when they say that they're recruiting ethically. What do they mean by that. Show me the evidence of what you are doing to back up that that claim. I hear, and I'm not talking about good recruitment practices. You know, there are issues with recruitment agencies who are going to countries and supporting people to move. Sometimes that's great, sometimes that isn't so great. But I'm going to the costs that you are offsetting here by not educating enough of your own workforce. So I thought, let's get those costs and let's get those numbers out on the table, because it's not billions, it's not millions, it's running into absolutely billions. And then let's have a conversation about, well, look, if this is the cost that's being offset, you say that you're committed to ethical recruitment. How could you demonstrate that financially? Write off some sovereign debt. The nurses who are coming into your country are paying taxes in your country. What about a proportionate take of that contribution in tax that they're paying going to support nursing development, health workforce development in other countries? And I think we as nurses then we not only need to raise some of those questions, but we need to follow through that the money really does go back into the health workforce. Too often the health ministries in countries who are losing nurses are not round the table. These are seen as trade negotiations or trade discussions as well. And where philanthropy is hugely important, but often focused on a specific disease condition. So it's money for diabetes or public health. And it's not, so we need to not only have the macroeconomic arguments about the money, where you could raise it from. I'm not an economist, but we can start that discussion, but then follow it through that it goes into health workforce development.
It's a really interesting point that you raise about the single disease issue. I remember interviewing Dr. Nick Crisp, Director General at the Ministry of Health in South Africa. I'm sure some of you will know. And Nick sitting down with me over a glass of wine and saying, if I get one more donor trying to throw money at me for AIDS, I'm just going to scream. AIDS isn't my problem. You know, my problem is diabetes. My problem is cardiac issues, et cetera, et cetera. The point about sovereign debt is a really interesting one. I do wonder whether that might be slightly above our pay grade to be able to negotiate reductions in sovereign debt. But I do appreciate the economic argument. And Geraldine, I want to come to you again with your experience, your experience at USAID, because I'm sure this issue of what does ethical migration look like in nursing has come up in those kind of conversations. What was your answer as USAID to that issue of ethical migration and putting money back into these health economies?
Thanks for that question. I would say, and I think a point that I wanted to bring into our conversation at this point is, it's yes, critical about the financing and how much we're paying. It also matters what the regulatory environment looks like in the countries for the nursing profession. So for example, in a number of countries, their Nursing Practice Act that regulates the practice is 30 plus years old. It's not current. It doesn't reflect what the current scope of practice is for nurses in many cases. So the people who are left on the line is the nursing workforce when the scope of practice is out of date, because they are expected to be the people that fill in the gaps, regardless of whether it's in their written scope of work or not. They are expected to sort of just make it work, to fill in the gaps in the healthcare system. And I think that's a critical piece of the conversation around migration too, is if you're recruiting from countries where people are so under-resourced and overstretched in what they are expected to perform in their day-to-day duties, and in addition to that, they have no defined recognition for advanced scopes of practice for the profession, or they're not able to, they've done specialist training, but they get no additional pay or recognition for it, that also drives migration. So we were investing in a lot of nursing leadership programs, investing in recognition of specialist competencies, and trying to help get those codified in updated scopes of practice for the profession.
I wonder, and I'll come to you, Robin, on this one, if I may. One of the key themes, I think, of the next 3 days, and certainly one of the key drivers for the Saudi Commission, is this idea about harmonization of credentialing, of being able to get to the point at which we have something approaching a global regulatory regime. It's probably, a kind of mystic urn somewhere off in the clouds somewhere. How possible do you think that is?
I think the harmonization piece is critical, and it's country to country. It's tied to accreditation of nursing midwifery programs as well. I don't want to disregard regulatory bodies and their roles. So their role is to regulate, to make sure that it's safe practice for nurses and midwives and other licensed professionals as well. But they're directly related to the accreditation of the programs that are in those countries. So they're not separate. You cannot untangle them. And some countries do a better job, but they're countries that have other country mentors. And a case example is Liberia. So Liberia is a very poor country, but networking, what everyone is doing here today, is critical, and it's critical for us in nursing as well, and midwifery. The director of the Liberian Board for Nursing Midwifery was at a conference where Ghana was presenting on their electronic licensing examination. They said, oh, this is a brilliant idea. We were very fortunate, and we were working on a 5-year HRSA grant with Liberia to have some leftover funds. So we supported Ghana mentoring Liberia in this electronic licensing exam. Liberia has taken it beyond. In preparation for this conversation, I wanted updates. They are now independent. So Ghana served as their mentor for some time, but they have the context of their country. So they have really blown it out of the water for electronic licensing exam. But what that does is it maintains the integrity of the academic programs and the integrity of those that are becoming licensed. And what we have through all of these countries, and you know this well, is there are many pop-ups, so to speak, of nursing and midwifery programs that the general consumer is not aware of. So nurses and midwives are graduating from programs that are not accredited. Therefore, they cannot sit for the licensing exam in their country. It's very complicated.
It's a really difficult problem, isn't it? Because at the end of the day, I mean, there's a couple of things here, I think, around. I mean, for one thing, you can't have a one-size-fits-all approach to regulation. We talked about this, Alison, you and I, earlier today. You know, there are going to be cultural considerations. There are going to be differences in the methodology of how practice is performed, differences in levels of technology, et cetera, et cetera. But there is some commonality there, isn't there? Susan, I think you wanted to come in?
Yeah, my hand's going up because this is what I did my PhD on. I feel globally we need to have a common core competency standard for nursing. Yes, there are cultural differences. There are essential drugs lists that vary. There are scopes of practice that may differ. But the basic core competencies of nursing are universal. And really focusing on primary health care and global health security. I think if we had a global framework for that, the health of the world would change dramatically, as well as health security. But we need to have that global standard.
But how realistic is that? I mean, certainly if I look at the regulators in my home country, I look at the General Dental Council, General Medical Council, the Nursing and Midwifery Council, regulators, I mean, this may be a controversial thing to say, and somebody can always slap me if I'm saying the wrong thing, but regulators in a lot of countries are process engines. You know, they're process engines. You know, what you have is you have applications in, checkbox exercise, yes, no, regulation out. So I know you're itching to come in here, Alison, so I'm going to ask you a really difficult question. How do you know, when it's that kind of, we always do what we always did, this is our process, how can you influence change in regulation? I mean, I think the Saudi Commission is a little different because they're a hugely unique organisation. You've got postgraduate education and training, regulation and credentialing all in the same place and with a commercial and strategic lens. But that isn't always the case in most regulators, is it? So how do you influence change in a staid organisation like a healthcare regulator?
Well, for places that have established regulatory bodies, it's asking, why do you still do it this way? Is there a new way to do this? Are you reflecting what's actually happening now? For places that are new, that are emerging, the biggest thing that could happen is put the data in the hands of nurses. Most of the time, nurses are not in charge of their own data. They're told they can't be because they're not believed that they are competent to handle that. But I can tell you from implementing a study during COVID where we have over 13,000 participants worldwide and had teams implementing data collection, give nurses a protocol for data collection. They will collect the data. teach them how to organize and manage it. And just like Robin's case in Liberia, they will be able to self-regulate and have the autonomy and authority to govern, because that is one of the critical things that happens is nurses may be represented in these regulatory bodies, but they may not be allowed to speak, or they may not feel comfortable speaking in these situations. So it's both that autonomy and authority to take action, but also to be able to get the data that they need.
So annoyingly, we only have 3 minutes left, which is actually really annoying because I'm really enjoying this conversation. So I'm going to give you a challenge now, and you've got to, the real challenge is whether you can keep this to 30 seconds, because that's how long each of you have got. I'm going to start with Howard. You've got 30 seconds to tell me what we as a global healthcare community need to do. What's the number one priority in terms of solving the problem of the oversupply, underutilization, underfinancing of nursing? 30 seconds, go.
We have just had really significant World Health Assembly, where the World Health Assembly unanimously supported the extension of the global strategic directions for nursing based on the latest State of the World's Nursing report. We lobbied and argued this from ICN. I was in the room and I heard member states say things that if I'd have written, I'd have been quite happy to have claimed those, because they talked and gave all of the words about supporting, strengthening, not just doing it tomorrow, but the importance of accelerating on recruitment, on retention, on leadership, on regulation, the modernisation of regulation. We have a clear, WHO has a clear steer. I think there's a really important job of advocacy for us to do, to have the conversations with our national leaders about whether they are delivering on what their representatives said in Geneva.
That was a bit more than 30 seconds, but it was a great point, so we'll let it go. I was there, actually, at the WHO with the Saudi Commission, and I know there was huge support for that. Robin, to you next.
Briefly.
Practically, on the ground, not talking, not coming to big meetings, what can be done?
So it's already been done with some diasporas, and I mentioned diasporas intentionally, so that out-migration to other countries, they create diasporas in the country that's receiving them. Ghana is doing a fabulous job. They have the Ghana Diaspora for Nursing and Midwifery that are working with nurses from Ghana in the US, and they're encouraging them to go back to Ghana to share their wealth there. Informal, but it's working.
Absolutely. One of the key points about migration, isn't it? Go and work in another health economy, gain the experience, gain the knowledge, take it back to your home nation. Susan, 30 seconds.
Fully empower the chief nursing officer of a country. Often they play second fiddle to others within ministries of health. Give nurses the voice, and then you will see really proactive change.
Understand the importance of nursing. That's the absolute key. Geraldine.
Engaging in nursing, having nurses engage in policy discussions and in regulation cannot be an afterthought. Regulation and the situation of that in a country either can allow conditions to persist that drive burnout, cause nurses to leave the profession, or it can be the things that make them advance and want to stay in their roles, and we've got to be engaged in those spaces.
Recruiting people, empowering them, motivating them, making them want to stay in the profession and do good. Alison.
I would be remiss as a health services and workforce researchers if I did not go back to the data point. We need better data, we need better quality data, and we should put the data in the hands of nurses to be able to take the action that's needed, because the data will also show us the relationships between socioeconomic development and where prioritizing investments should be.
4, 3, 2, 1. Perfect. Give these guys a round of applause.